Greetings. It's a great pleasure to be with you today and be asked to present during this very important Congress hosted by the Center for Vein Restoration. And I'm indebted to my dear friend Peter Pappas for inviting me to join the meeting. And I'm going to discuss a subject today, although it relates to old studies, are very, very important and critical in the care of the patients that we have with DVT. I have included Feder Lurie in this presentation, a dear colleague and a very well-known and excellent scientist, because he has taught me some things during a recent presentation of his that I thought were so compelling that I thought we should pass them along. First of all, let's talk about the post-thrombotic situation now. It's called the post-thrombotic syndrome, but really it's the post-thrombotic disease. And it's a collection of symptoms and signs that occur many times after a blood clot has formed in the legs. And we see the use of compression stockings in these 4 meta-analyses show a clear benefit of using compression stockings to help prevent or modify those symptoms. And then all of a sudden comes the SOX trial, 2014. And as you can see, that trial does not favor elastic compression stockings for the prevention of the post-thrombotic syndrome or symptoms at all. And does this mean that it's a game changer? At the time, it was billed as a game changer. And here's the original study, and the findings from this study. There were 410 patients in the stocking group and 396 patients in the so-called control group, and we'll discuss that so-called later. And the cumulative incidence of PTS syndrome was no different in 2 years. And in the words of the authors, external compression stockings did not prevent post-thrombotic syndrome after a first proximal DVT. Hence, our findings do not support routine wearing of external compression therapy after a DVT, a statement that would ring in the ears of thousands of people around the world when confronted with patients with a DVT, especially in the acute phase. And here we see the graph showing there's no difference in these patients. Now, let's take a careful look at this trial. Compliance after 2 years was low, with only 55% of the patients using compression stockings about half of the time. Half of the patients wearing stocking half of the time, to me, is not an adequate test. Patients didn't keep a daily diary, and the authors relied on their questionnaire about how often the stockings were used. Well, how can you do that? What did you do last week, last month? How many days did you do this or do that? That doesn't make any sense to me. Those of us seeing thousands of DVT patients noticed marked improvement in signs and symptoms once appropriate stockings are worn. It's a great disservice to these patients to suggest that they do not need to wear the hose. In fact, when patients are not compliant, their symptoms or signs reappear. We face these non-compliant issues in our clinic daily. Patients with more severe PTS sometimes need flat knit stockings and higher pressure stockings or Velcro devices. I don't have time to talk about Velcro devices today, but Velcro devices are one of the most important modalities because a certain percentage of patients either can't wear stockings or the stockings don't fit appropriately or they have trouble donning and doffing. Critical measurements of the leg circumference of both initially and subsequently in both of the groups in this study were missing. The Ginsburg criteria and the Villalta score do not at all quantify edema, since it's left to the discretion of the observer. Relying on patients' word is a very weak index of compliance. Clinical experience would indicate that patients exaggerate their use of compression therapy. They got very expensive stockings for free. Naturally, they're going to say that they were using them. That's only human nature. Since only half of the patients volunteer compliance at 2 years, one might say that represents a fatal flaw. Now, I've been wearing hose myself, now, especially now that I'm in my 80s and teaching compression for over 40 years. And I can't imagine not being able to tell whether I was wearing a no compression stocking versus an appropriate therapeutic compression garment. In the active elastic compression group, 59% of the patients, 76% of the research nurses, and 87% of the site investigators provided either a wrong guess or answered uncertain about whether patients were wearing active or placebo stockings, suggesting that they remained unaware of the treatment allocation. I find that astonishing, and I was always puzzled by that. But I learned the answer from Feder Lurie. Feder reminded us that the work of Parsh and Mosty that provides one possible explanation for this paradox. They showed that progressive external compression stockings, where the pressure at the ankle is lower than the pressure over the calf, have been shown to be more effective than graduated compression stockings. Think about it. Around the calf, you've got tendons and bone. Around the ankle, you have tendons and bone. Around the calf, you've got all the mass of blood vessels and the greatest area of venous collection. And compressing that more of the blood should go out of the leg. Not only that, but they also showed that low pressure progressive elastic compression therapy, again, that's where the calf pressure is higher than the ankle, have shown equal efficacy compared to high pressure graduated compression therapy to reduce swelling and provide symptomatic relief. Heretical comments if it weren't for their excellent data. And so up to now, all of the things that I've said about the trial, except for Feder's comments, are just another opinion. I understand that. But as Feder has pointed out to us, Sigvaris Corporation manufactured the open-toe, knee-length beige cotton active and placebo stockings used for the study. Active stockings had a 30 to 40 millimeter compression at the ankle and were manufactured according to the company's specifications to ensure correct fit and accurate compression. Placebo stockings were manufactured to look the same as active stockings, but to have no therapeutic effect, less than 5 millimeter compression at the ankle. And they were available in 16 sizes. Now, what's interesting is that if you've ever worn any kind of a stocking, you know, even if it's a light stocking, it has to have some pressure around the calf. Otherwise, it'll fall down. So in order to prevent the stockings from falling down, there was a 7 to 8 millimeter pressure in the calf with a 5 millimeter compression at the ankle. Oh, we have the progressive external compression stockings that have been shown by Hugo Parsh and Giovanni Mosty to not only provide more pressure and more blood flow out of the leg, but also be as effective or more effective than graduated compression. Thank you, Feder, for that wonderful answer, because that always puzzled me how people could tell the difference. And here we look at the graduated compression stockings and the progressive ones with the higher pressure at the calf, and you can see the foot volumes are less when you're using low pressure, even compared to no stockings. And then if we go a little bit further, B1 is the junction of the muscle and the tendons in the calf. C is the maximum diameter of the calf. And you can see here that the supine interface pressure was higher at B1, where the tendons and muscles meet, than in the calf for the standard graduated compression. But with the progressive compression, it was just the opposite, with a dramatic increase in pressure in the calf. And that's no surprise because there's more blood in the calf to be pumped out of the leg. And if we take a look at the standing interface pressure, we see the same thing. 16 for the graduated compression, 28 for the progressive compression, clearly showing some scientific data, not just an opinion, to back up the data. So, as Feder has so well put, the interpretation of the trial that the compression stockings after a first DVT did not prevent the post-thrombotic syndrome, and we do not support wearing routine stockings after DVT, is wrong. The correct interpretation is low pressure anti-graduated stockings prevent PTS after the first proximal DVT at a similar rate compared to 30 to 40 millimeters graduated compression stockings. Quite a difference. Nevertheless, the authorities missed this completely, and this is a recommendation from the Consensus Conference in 2016. In patients with acute DVT of the leg, we suggest not using compression stockings routinely to prevent the post-thrombotic syndrome. Now, unfortunately, they did put a caveat in the fine print, but most people don't read the fine print. And they admitted that for patients with acute or chronic symptoms, a trial of stockings is often justified. Really? But yet, that flies in the face of the conclusion of the study, which said not only do the stockings not prevent a DVT, but our findings do not support routine use of a DVT. So I don't know how many hundreds of patients I've seen since this came out. They get a DVT, they'd go to the emergency room, they'd be given anticoagulants, told to call their doctor. The doctor would say, well, call up a specialist to find out about your clot. And so they would come in to see me, and I would say, where are your stockings? Oh, my doctor told me that they're not recommended anymore. Well, how's your pain and swelling? It's terrible, doc. That's one of the reasons I'm here. I've taken all this medicine. Why do my legs still hurt? Well, you have to put them in stockings, and putting them in stockings, 85% of them did well, 15% didn't. And then we would have to go to Velcro devices. I would also have to show people how to put them on and off and observe whether they could do it and give them certain aids. None of that was done in the trial. So let's go a little bit further. What did they use in that trial? One of the limitations was using the Villalta score, which has been shown to misclassify 42% of patients with primary chronic venous disease as having PTS. Not only that, but their observation period was 2 years. And here we show another study. Now, this is a different, this is endovascular intervention, but shows the result at 2 years versus the result at 5 years. And you can clearly see that 5 years needs to be the appropriate time period for follow-up. Now, here's a very interesting study that came out in 2016, 3,600 patients, and they had proven deep vein thrombosis and had been treated with appropriate guidelines. And one of the interesting things here is that at 1 year, patients had a 2.6% incidence of PTS. But look what happened. Look down here at the real life statistics. Already stopped wearing. Didn't want to stop wearing. Impossible to wear. Those three categories are typical of every population you ever put in stockings. That data is missing in the SOX trial. And then there's an additional meta-analysis that shows that patients can be informed that there's a 95% probability of some reduction in the risk of post-thrombotic syndrome of any severity, and 82% probability of observing some reduction in the risk of severe PTS using compression therapy. Large benefits are unlikely. The probability of reducing the odds of any PTS by half is 50%, and the probability of the odds of severe PTS is 16%. So, in conclusion, ladies and gentlemen, compression therapy should be used for the prevention of secondary post-thrombotic chronic venous disease after DVT. That's the best practice. We've been doing that for years. Modalities including graduated compression stocking or progressive external compression stocking using pressures tolerated by the patient are appropriate. They don't always have to be high pressures. Parsh and Mosty have taught us that lesson. Careful stocking fitting, application and removal techniques are imperative for proper compliance. You've got to watch the patients putting the stockings on and off. And if you look at some of my videos, you'll see there's many, many ways to easily apply and remove stockings, but it's not for everyone. And some people will need Velcro compression, valuable for those unable to wear stockings. And now they're producing products that are not only Velcro strap-like, but other strap-like devices that are equivalent, that are very, very effective, very easy to use for the patients, and very valuable on the long term. Immediate compression to control the pain, swelling, and discomfort associated with symptomatic DVT is a necessity to prevent chronic changes. And those of you that don't know history, go back and read Parsh's seminal papers in 1999 and 2000, where he showed that compression therapy initially markedly decreased the pain, swelling, tenderness, and improved the patient quality of life scores right from the beginning. That first 2 weeks is critical. And we know nobody in the SOX trial got stockings for at least 2 weeks. Compression therapy should be used for the treatment of C3 to C6 DVT of any etiology. We need to use the SEEP classification, and this is an important consideration. There is an urgent need going forward. I don't say we have all the answers. We need appropriate definitions using SEEP, appropriate severity scores like the VCSS and the quality of life score, appropriate follow-up time, 5 years or more, and appropriate outcome measures, including duplex ultrasonography. I'd like to thank you, ladies and gentlemen, for the privilege of presenting this for this presentation. And I would like to thank Peter Pappas and the Center for Vein Restoration for allowing me to present these data. I hope all of you stay safe and have a great day. And I'm looking forward to a very lively discussion. Thank you very much.